Good morning or afternoon, everyone. I'm Latanya Hammond-Zodi, and I am an associate professor of biology at Georgia Gwinnett College in Lawrenceville, Georgia. And today I have the pleasure of serving, as the co-chair of the ASCB Minority Affairs Committee, or the MAC, along with Dr. Michael Boyce, who's an associate professor of biochemistry at Duke University. And today, I'm here to introduce the awardee and the speaker for the 2020 EE Just Award. So I'm going to start by actually talking about the MAC a little bit. The Minority Affairs Committee of the ASCB, besides the EE Just Award lecture, we also have several programs that are centered around professional development from undergraduate stages through junior faculty stage. The MAC was actually became a standing committee of the ASCB in 1985. And our mission overall is to basically help faculty all the way down, as I said, to undergrads, but in terms of both faculty at teaching institutions and at more research intensive institutions. We have, as I said, we have several programs, and if you go on the ASCB website, you can find out more about any of these programs and what the purpose of each one of these would be. Now, today we are recognizing minority scientist for his accomplishments, and the award is named in honor of Ernest Everett Just. And we've been doing this since 1994. For those of you who don't know about Ernest Everett Just, he was a African-American scientist in the early 20th century. And in this picture from around 1925, he's at Marine Biological Labs in Woods Hole, Massachusetts. A little bit about Dr. Just. He was born in South Carolina. He started going to a boarding school at the age of 16. He graduated from Dartmouth before moving on to the University of Chicago and getting a PhD in zoology. He struggled to find a faculty position at any major university in the United States because of his race, and his field of research was actually looking at cell surface molecules in terms of embryonic development and fertilization. He used marine invertebrates as his model system, which fit really well and explains his tenure at Marine Biological Labs. He was clearly a pioneering cell biologist, and a lot of the molecules, cell surface molecules and interactions that they have, we know about them because of his work. He did publish 2 books, and he's influenced, as I said, developmental biology and evolutionary biology. If you want to know more about Ernest Everett Just, there is a book about him. Was written in 1983 by Kenneth Manning, Black Apollo Science. And a couple of years ago, Dr. Malcolm Barnes wrote an article about Dr. Just as well. So moving on. So today we're here to recognize the accomplishments of Dr. Lovell Allen Jones. We're pleased that he's been able to recover from COVID and is able to give this lecture today. He has had a very distinguished career. He received his doctorate in 1977 in the field of zoology with an emphasis in endocrinology and tumorology from the University of California at Berkeley. His graduate training was under Dr. Howard Burns and he was an NIH pre-doc trainee and a Ford Fellow in the UC Berkeley's Cancer Research Lab. After his doctorate, Dr. Jones did a postdoctoral fellowship in reproductive endocrinology at the University of California, San Francisco under Dr. Pinti Ceteri. And then he joined the Department of Gynecologic Oncology at the University of Texas M.D. Anderson Cancer Center in 1980. And he was also an instructor at UCSF in the departments of physiology and in obstetrics, gynecology, and reproductive sciences. Dr. Jones was the first African-American to rise through the academic ranks to full professor and to hold an administrative title at the University System in Texas. Until his retirement in 2013, Dr. Jones was a professor in the Department of Health Disparities Research, as well as a professor of biochemistry and molecular biology at the University of Texas M.D. Anderson Cancer Center, and a research professor of social work at the University of Houston. He's the founding director of the congressionally mandated Center for Research on Minority Health, which evolved into a joint University of Houston and University of Texas M.D. Anderson Cancer Center, Dorothy I. Height Center for Health Equity and Evaluation Research. By 2012, Dr. Jones had received more than $40 million in research and educational funding, and he's had over 130 publications, several book chapters and books. At his retirement from the University of Texas System, he was bestowed the title of Professor Emeritus in the Department of Health Disparities Research at the University of Texas M.D. Anderson. He's the first African-American to be bestowed that title. He was awarded his second Professor Emeritus title in April 2014 from the University of Texas Graduate School of Biomedical Sciences. This makes him one of the few, if not the only, African-American to hold dual emeritus status in the University of Texas system. He still holds an adjunct faculty position at Texas A&M School of Public Health, Texas A&M University of Corpus Christi, and Baylor College of Medicine. He writes for the Houston Style magazine on health. Additionally, Dr. Jones continues to provide opportunities for underrepresented minority students to train in the areas of health disparities and oncology through the Texas Medical Center Health Disparities Education Awareness Research and Training Consortium. Because of his leadership and his commitment to that consortium, several trainees of his are carrying forth his mission, and they host an annual summer workshop series where undergraduates and graduate students from diverse communities around the country have an opportunity to engage with national, internationally renowned scientists in the field of health inequities. In his opinion, one of Dr. Jones's greatest accomplishments has been the hundreds of mentees that he has trained throughout his career. He clearly understood that the path to success in the biological sciences is not easy, especially for students of color, but he maintains and actively assists all of his mentees throughout their careers and continues to do so. Please welcome Dr. Lovell Allen Jones, the 2020 ASCB MAC Ernest Everett Just Awardee. Thank you, Dr. Jones.
The title of my presentation today is Addressing Health Disparities or Inequities through a Biopsychosocial Approach, one person's view. I use these terms interchangeably, but they really are not. One is more causative and the other is more descriptive. Disparities really is more descriptive. Inequities is more causal, and you'll see why I classify them in this way. But the title is a drumbeat I've been beating for more than 2 decades because I realize for a change to really occur in health disparities, we're going to have to do it in a holistic manner. I also realize that for change to occur, you have to change the workforce at not only the level of leadership, but also at the grassroots level. Therefore, my subtitle that I've included, Changing the Course of America Through Mentoring, which has been my other passion. But before I really get into this, I want to thank Dr. Stacy Lloyd, Dr. Deborah Murray, and Dr. LaTanya Hamill Odis for nominating me, and for the American Society for Cell Biology's Minorities Affairs Committee for selecting me as the 2020 Just Awardee. I also want to send out a special thanks to Shanti Edwards and the American Society for Cancer Biology, its leadership for its patience in scheduling my lecture. And lastly, thank you, Dr. Hamill, for your kind introduction. Because who we are shape how we look at the problem, mentoring the next generation is essential if we're going to address this problem. But before I proceed with my presentation, I would also like to highlight a few of the many individuals I owe this journey to. There are many more than I could ever talk about. However, let me recognize these two individuals that were at a major junction in my career path. Dr. Christopher Hartree, who recognized the potential in me. If it were not for him recommending me for graduate school, to a close colleague at UCLA for entry into their graduate program, and then my wife for seeing a flyer recruiting minority students at UC Berkeley, the chances of me being before you today is probably slim to none. So I entered UC Berkeley as a 42nd student out of 42 students admitted that year. And as I would say to, and have said to my students, is not where you start, but where you finish. For me, finishing as the first African-American in the Department of Zoology and the first in its endocrinology group program, to not only graduate, but graduate as one of its top students. Ironically, the department and the program no longer exists, but here I am. I've been referred to as a Renaissance scientist, but I truly owe this to my graduate mentor, Dr. Howard Byrne, who's one of the true Renaissance scientists. He was one of the last noted endocrinologists in the nation whose research covered every aspect of endocrinology from invertebrates to vertebrates. I believe my approach to addressing health inequities stems from this holistic approach that I've trained under. One of the other key things that was instrumental and instilled in me by Howard was mentoring, that one's legacy to science is not the work that you do, but the people you leave behind. I think that the majority of the individuals who trained under Howard came away with that philosophy. He once said to me, couple your science with your passion for addressing discrimination. Always let your science be the rock you stand on. Never stop focusing on the science as your rock. Even in quicksand, that rock will support you and keep your head above water. In seeking students, always focus on that person with passion, because they will become indistinguishable from the one who knew their path at the beginning. Always encourage those of diverse backgrounds to identify the idea of independent study. It will take years, but in the end, the thread creates the possibility to form the rope that provides the foundation to change destiny and leave a lasting legacy. I've lost track of the number of students who started training, who started training with me. First as a postdoc at UC San Francisco in 1977, until I stepped down as the founding director of the HEART Consortium in 2017. But this letter from Dr. Evan Warner kind of says it all in terms of what Howard said. Dear Lovell Allen Jones, you have no idea how the center influenced me and my life. I have never in my life met so many educated minorities. If you never hear this from another student, you made a difference in my life. I saw you do and achieve so much in my 3 years with the center. Therefore, I shall. Thanks for taking a chance on me. You were a mentor to all of us, and we soaked it all in. Thank you from the bottom of my heart. Next year, I actually start my doctorate program from an accountant clerk in your center to a doctor. Who would have guessed? If one combines those trainees who've come through my lab and various training programs, the numbers we have touched, and I say we because it takes a group effort to make this happen, are in the hundreds, maybe in the thousands. The following are a few others whose careers will hopefully exceed mine. I contacted some of them when the American Society for Cell Biologists honored me for mentoring a few years ago. I asked them to tell me their greatest accomplishments. Imagine my delight when I got their slides. Dr. Jerry Guyton was among the first minority individuals that I helped to recruit to the University of California, Berkeley. Although he was not in Howard's research group, he became one of his mentees and ultimately mine. You will notice the first thing he lists on this slide is mentoring. In 2011, you honored him with the E. Just Award as well. Dr. Patricia Miranda said, being able to serve as a mentor myself as a tenured track Latino faculty member is one of her greatest accomplishments. One of her publications as a fellow in my lab was featured in 10 major newspapers across the country. Dr. Amy Snipes, one of the few African-American biological anthropologists in the nation. She formally refers to me as Papa Jones. Being able to serve as a mentor myself as a tenured track African-American faculty member is truly an honor. Dr. Natalie Rivera Valley, who finished her PhD with a colleague, said, he's been more than a mentor. He's been a father to me. I often say that a person's perception is a person's reality. If you take nothing else away from this talk, think about how this plays out in your everyday life, especially with regards to the issue of equity. These individuals were less than a mile apart. Again, think about perceptions versus reality, how they play out. In one picture, the individual is looting, and in the other, they are finding. I should mention that the person that they refer to as looting was a college student at Xavier University in New Orleans. Einstein once said that insanity is doing the same thing over and over again, expecting different results. For instance, the way we have approached health inequities and do clinical trials. And today we've made little real progress in addressing health inequities. How many decades, yes, decades, have we said we have difficulty in recruiting minorities to clinical trials? And that problem still remains with us. Miles Mabley once said, if you always do what you've already done, you will always get what you already got. And unfortunately, that's health inequities. When we approach efforts to deal with the lack of real progress in addressing health inequities, we tend to fall back to what we've done before. It may be under a different name or packaged in a different box, but ultimately it's the same strategy. Think about it. Now, before you begin to think that I'm this flaming radical with a chip on his shoulder because I'm a scientific failure, I believe I'm far from a failure. In fact, I consider myself a tremendous success story, coming from a young boy in Baton Rouge, Louisiana, from a segregated neighborhood to now a distinguished professor. You see, when I was on the faculty at the University of California Medical School in San Francisco, I was thought to be a budding young molecular endocrinologist. My research had already begun to make an impact on the field of reproductive endocrinology and hormonal carcinogenesis. Starting as a graduate student in Howard's lab, helping to launch the field of hormonal carcinogenesis, to retiring as doctor of the Joint Congressionally Mandated Center named the Dorothy I. Center for Health Equity and Evaluation Research. I also ended up as a full professor in the Department of Health Disparities Research at UT M.D. Anderson, and as a full professor in the Graduate College of Social Work, as a professor of social work. Never taking a social work class in my life. This slide is where my career started, helping develop the field of hormonal carcinogenesis in developing an animal model to determine the molecular mechanisms of early exposure that would lead to the development of cervical vaginal cancer in women who were exposed to astrobestrol early in life. Then an event took place as a postdoc during my journey that brought my passion back into play and changed my life's and scientific career path. That event was my mother developing breast cancer. I then came to realize that no matter how many discoveries I made, if it did not impact the people I loved, it was all for naught. My research was on breast cancer, and here was my mother with a large tumor that she knew was there, probably for several months, but believing cancer was an automatic death sentence. That couldn't be. But messages like this that's contained on this slide were not readily seen in my mother's neighborhood or in other minority and poor communities in the US. As the late Congressman Tip O'Neill once said, all politics are local. I say all health is local. Therefore, when looking at addressing health inequities, not only national incidence and mortality data should be considered, but also regional and local data sets as well as how one delivers that message. These words were spoken by Dr. David Williams over a decade ago and are still relevant today. But unfortunately, the list is getting longer. Don't get me wrong, we have made some progress, but unfortunately, it's not in the realm of health equity. Which brings me to COVID-19 that laid bare a real lack of progress in addressing the issue of health inequities and the differences between the words health disparities and health inequities. So that we're clear, health disparities really is differences in incidence, prevalence, mortality, and burden of disease and the other adverse health conditions that exist among specific population groups. Descriptive. Health inequity really concerns those differences in population health that can be traced to unequal economic and social conditions and are systemic and avoidable, thus being inherently unjust and unfair discrimination. Health in minority communities cannot be approached as a single issue. It has to be done in a holistic manner. And that's what my talk is about. In moving from the faculty at UC San Francisco to UT M.D. Anderson, From 1980 to 1985, I should say, I continued to work on transforming what I'd done with breast cancer at UC San Francisco to ovarian and endometrial cancer, as well as continuing my work on the mouse model, creating that solid foundation, the rock, to work from. In 1985, an opportunity arose when the National Cancer Institute identified the month of May 1985 as Black Cancer Awareness Month. That event made it clear to me that to address health disparities, as it was called then, that was facing minorities and medically underserved populations, one had to develop a new research paradigm, a paradigm in which it needed to be recognized that health in minority communities could not be approached as a single issue, but in a holistic manner. As my good friend Harold Freeman stated, the existence of health disparities is not just a scientific and medical issue, but a moral and ethical one. In 1977, George Ingold eloquently stated, to provide a basis for understanding the determinants of disease and arriving at a rational treatments and pattern of health care, a medical model must also take into account the pattern of the patient, the social context in which he lives, and the complementary system devised by society to deal with the disruptive effects of illness. That is the physician's role in the healthcare system. This requires a biopsychosocial model. In 1999, I changed Dr. Ingold's statement to reflect a more multidisciplinary approach to health disparities, a medical model that must take into account the complex nature of health disparities that involves more than problems with access. It takes into account community, the social context in which they live, and the complementary system devised by society to deal with the disruptive effects of illness on their lives. That is a problem that can't just be solved at the bench or in the clinic or by analyzing data sets. If the problems are in the community, then the community must be involved in determining the solutions. It is a paraphrasing of one of the late Gail Friedell's, former director emeritus of the University of Kentucky, Cancer Center, a Gailism. If the problems are in the community, then the solutions are in the community. And spending close to 40 years addressing inequities and reviewing what works and what doesn't work, I have boiled it down to these six key words: trust, respect, partnership, communication, flexibility, and knowledge. I could give you a whole lecture on each one of them and the role that they are essential in terms of addressing health disparities, but maybe at a later date. Simply stated, a biopsychosocial approach to addressing health inequities is an approach whose research envisions is inclusive and has a contextual framework that integrates molecular, cell biology, behavior sciences, as well as the social sciences, political sciences, economics, history, anthropology, and others. It acknowledges all possible influences that might affect health and the quality of life, both positive and negative. It is the understanding that health cannot be addressed as a single issue, that it has to take into account other factors that influence the actual as well as the perceived need of healthcare and attention to health concerns. It takes into account these multiple factors that contribute to health disparities. Overcoming this challenge will require comprehensive and holistic solutions. Progress will remain elusive if we continue to address the problem as silos with single contributing aspects in isolation. And although the health reform legislation that's recently passed has helped address one facet of this, access, the recent pandemic has again showed us that the solution continues to escape us. So here are 7 problems that I believe account for the majority of why we're still facing health disparities, inequities, and the opportunities for change. First, health is really not a national problem. If it were, the health, the budget, and what we are spending on to address health inequities would exceed what we are doing today. Just look at the defense budget compared to our health budget. Disparities in health in America, are they real? A large percentage of white Americans still think they're not. Have the knowledge but lack the will. We know what to do, but I think we don't have the will yet to do it. Race is a biological construct, is a blessing and a curse. A blessing in that we have something to use to measure in terms of the differences with regards to inequities. A curse because it lacks, it's more of a social construct than a biological construct, which leads to the other issue of race, racism, racialism, which are not resolved. You might ask the question of what racialism? Racialism is the discrimination that occurs where race is not involved, such as in Appalachia. I had the opportunity to work with Gil in that part of the country and see some of the health inequities that existed in that population. But when they went to the large metropolitan areas for healthcare, they were told not to open their mouth because if they opened their mouth, the person knew where they were from, and the health in terms of the availability of care would decline. That's racialism. The last is immigration, demographics, and health, and the implication of what's occurring along the border today in terms of addressing health inequities. Then it takes, let me focus on the hardest issue to address, the one that still haunts us today, and that's race. Race, perhaps the single most defining issue in the history of American society. I found that over the years, health inequities is probably the best indicator of the failure of this nation to address the issue of skin color and our social class. It truly has a bearing on the future well-being of this nation. It is the measure we should use to define progress. Given the amount of time I have left, let me get to what I see as a solution to health inequities. There are 5 elements originally written in the 80s for establishing an effective cancer education program, but are relevant to addressing health inequities. The first states that a committee which plans to provide the program should include persons who represent population targeted to be served. The second is major items should refer to the local cancer or health plan. If one doesn't exist, one should be developed before proceeding. The third is use a wide range of health, education, communication methods to capitalize on the strength of each. This should be done with community and not without. The fourth, the need for a procedure and or instrument to measure success. And then last, the need for sufficient funds and manpower to carry out the plan. If you don't have one, I would suggest don't start until you are sure that you can complete and implement the program. Then there are the guiding principles. These I came up with when I was with the Institute of Medicine looking at environmental justice, and I think they also apply to health inequities. A coordinated effort is needed to improve the collection and coordination of health information and to better link this to specific populations and communities of color. Research related to environmental health or health disparities should engender three principles: improve the science base, involve the affected populations, and communicate the findings to all stakeholders. And lastly, in instances in which the science is incomplete with respect to environmental or health disparities issues, it is urged that those involved in such research exercise caution on behalf of the affected communities, particularly those that have the least access to medical, political, and economic resources, taking reasonable precautions to safeguard against or minimize adverse health outcomes. And over the years, these are the lessons that I have learned. Lesson one, no one center or one institution or profession will serve the problems we face. Lesson two, if you always do what you already done, you always get what you already got. Lesson three, what is publishable may not be relevant, but what is relevant can always be made publishable. Lesson four, a true change in the paradigm is needed. Lesson five, a person's perception is a person's reality, whether real or not. Lesson six, if the problems are in the community, then the communities must be involved in determining the solution. Lesson seven, if you attempt to address a disparity issue as a single problem of just one disease without taking into account other factors, you've already failed to address the problem at the beginning, and the outcome would be like placing a Band-Aid on a heart attack. It may make you feel good, but what about the patient? And lesson 8. The solution to the problems revolves around, again, these 6 key words: trust, respect, partnership, communication, flexibility, and knowledge. This is the way that we have normally conducted research. The researcher thinks about the project, contacts the community, generates the data, gets a publication, gets additional funding, comes up with another project, and the circle continues. In the late 90s, as a member of this, in 2020, in 2003, I worked with members of the Trans NIH Health Disparities Task Force to help develop the above model. We use this in our research, and people always say, you don't have a problem in recruiting minorities. Question I have is, how many of you have seen this? This has been around for more than 20 years. Here's another model that has successfully been used both in terms of addressing health disparities, but more recently in addressing COVID-19. Again, the solutions to health disparity inequities will require no new laws, but a willingness on our part to change the way we address the problem. We'll take no new basic or clinical research, but an equitable delivery of what we know today. This is not to say we shouldn't do research, but we need to better link discovery with delivery. We really still don't do that. It will take no dramatic increase in new monies, but a change in the way in which we allocate the monies we already have. The problem or the solution to the problem will also require the willingness and commitment to take the first real steps towards solution. Again, if the problems are in the community, then the solutions are in the community. And we need to involve the community at the beginning, before we start, during the study, and discussions of the results and the implications. Again, we really don't do that. And we need to involve the community so that at the end, it ultimately becomes owner of the project. Lastly, the ultimate goal in addressing health inequity is to work to discover, to link discovery with delivery, and the community becomes the ultimate owner of the project. Because sometimes outside funding will run out. They really do. As stated, we've witnessed significant progress in increasing awareness of racial and health injustices. Two esteemed equity leaders told attendees at a Learning Series Leadership Conference this year that we have made significant progress in addressing the awareness of health disparities, but warned that any progress could be undermined by racism, political resistance, as well as institutional inertia. A recent statement by Michael Hyatt and Associates stated that one of the 2020's greatest gifts was renewed attention to racial disparities. Again, at the session with U.S. Surgeon General David Satcher and health policy specialist Daniel Dawes, they again stated, we have witnessed a significant progress in awareness of racial and health justice, and they warned that any progress could be undermined by racism, local resistance, and an institutional inertia. I repeat this because we constantly reinvent the wheel, and we've seen this over the last 2 decades. At a national meeting, I stated awareness is not enough. That is why we still have health inequities. And until we change our approach and realize that we need different approaches, the nation will continue to suffer from health inequities. I ask you to do one brave thing today and then run like hell. And when I said run like hell, addressing health disparities and health inequities to really make a change. may upset a few people. I continue to do this and push this rock uphill because of these individuals. I think everyone needs an envisioned future. Thank you. Any questions?
Thank you, Dr. Jones. There are a couple of questions coming in. So Amy Maddox says, this has been an inspiring synthesis of so many important concepts. Regarding the idea that reallocation instead of higher investments is needed, what wisdom can you share about persuading those who will be or feel like they lose in this zero-sum game? I want to imagine that I'm willing to give up advantages, but I am sure I'm overestimating my own generosity.
I think it's a change in the philosophy, and that is, as I mentioned earlier, not only a change in the leadership, but a change at the grassroots level. One of the problems that we have faced in this nation is a lack of true education. And that is, I tend to be Department of Education's worst nightmare, because I think that we've gotten away from how we train the young generation. And what I mean by that is that I would often point to the decline in the California education system over the last couple of years, or the last couple of decades. In California, when my wife first started teaching there, to teach in the school system, you had to have a degree in some specialty: history, biology, political science. And then you took an additional year to train and gain teaching techniques. We started a program here in Houston several years ago when I could not find a large number of minority students for my high school training program who had the background to really do well in it. And what I realized was the lack of training at the elementary level. Because most teachers, unfortunately, through no fault of their own, are not trained in the sciences or don't have a strong background in the sciences. And so when a student in the inquisitive first grade or kindergarten will ask about butterflies or caterpillars or something that they've observed, the teacher can answer the question. And because of their sense of embarrassment, they would come up with some sort of way of making it an issue that the kid asked a question. And that would kind of put a damper on their inquisitiveness. We need to find some way, and we did, but find some way of helping those teachers to be able to answer those questions and really stimulate students in terms of their inquisitiveness. We see it now. I just saw an editorial on Aaron Rogers about when did he get a PhD in epidemiology. Well, it's not Aaron Rogers or individuals of his status fault, because they didn't get the background with regards to, let me be very blunt, we are a science illiterate population. We who are educated think that most of the individuals in this country have some basic sense of science and be able to interpret what's going on. This pandemic has brought it to the surface more than anything else. But we are truly a science illiterate population. And that's an area that really needs to be addressed. So to answer your question, focus on the leaders, but also focus on the grassroots individuals as well. I hope that answers your question.
All right, next question is from Thelma Hurd. She asked, she said, the pandemic eroded self-efficacy, hope, and self-determination among young people of color in rural communities. How can we effectively reverse this trend?
Oh, that's a good question. I think through communication, we're going to have to think of better ways to communicate the issues that are confronting us, both in terms of rural America, but urban America, the inner cities as well. One of the things that, one of the last papers I wrote on before I retired academically was on what's called the post-traumatic slave syndrome. I don't know how many of you heard about that, but when I was looking at some of the issues that are confronting us in the inner cities, it mimics post-traumatic stress and the issue of how post-traumatic stress can be carried on in terms of generations. Look at the children of those parents or parent who suffered post-traumatic stress and the impact it has on their abilities in terms of school and society and so as well. I think it's going to take us really addressing it at that level. And that's why I say addressing health inequities needs to be addressed in a holistic manner, because there's so many factors that impinge on us being successful in addressing it. Hope that answers your question, but it's probably more in depth than that.
All right, next one is from Susan Eddington. She says, thank you for this insightful presentation. What role do you think media can play in affecting systemic change?
Media has a significant role. One of the problems that we face in this country too is a lack of real trained science communicators in the media industry. And that's why you will hear on one broadcast how this particular substance may be bad for you, and then on another broadcast, that may be good for you, and the public walks away with a confused nature. I think the media has an essential role in conveying what's needed to really have a unified society. I often wonder if cable news was around during the 50s, if we would truly be integrated today.
Interesting. Let's see. Lydia Villa-Komarov says that she thanks you for your lifetime of accomplishments and pushing us forward. And she wants to ask about, she wants to say the message is not new, but how do we amplify these important voices?
If I knew the answer, I probably wouldn't be talking. I've been trying to amplify this message for about 30 years in different forms. It seems to be a message that doesn't want to take hold, but I think it's a message that ultimately we're going to need. I think the way we are today. I've started a new initiative, I think, primarily because the way that I've been trying to address this has not worked in terms of conveying of looking at the issue as we're all in pain. And I think the pandemic has really brought that to the surface. And hurt people. No matter who you are, you lash out. And unfortunately, we're seeing that more and more. So I think one of the ways of addressing this is to begin to ask people what has changed in their life due to the pandemic. And has it been positive or has it been negative? If it's negative, how do we go about addressing it so that you don't hurt yourself and hurt others around you, and approach it from that angle?
All right. Amy Maddox dropped in a comment. She said, "Thank you for this excellent focus on education, including early education. Lots of work to do. Love it, grassroots."
Oh, thank you for that
And
comment.
Michelle Juarez dropped in a link to one of your articles. So thanks, Michelle, for that.
I wish my voice had been better. I started out being not hoarse, but now, but it's one of those lingering secondary impact in terms of fatigue, in terms of mental accurativeness that takes place. That is this, I guess, a comorbidity that comes with having. Some of us suffer from having COVID-19. But at least I'm still.
We're very happy that you were able to actually do this today. Seriously, yeah. We were not going to let you not do this to the best of our ability.
Well, I think I hope the message got across. We know what the solutions are. We don't need, not to say to my research colleagues who are still there that we don't need research, but we need to figure out how to communicate what we already know effectively. I think if we learn that, we will go a long way in addressing equity across the board. If we can begin to get that message across to those individuals who I call them the Trumpies, that they are in the same boat, and the hole at the end of the boat that we're sitting in is the same hole that will take them down as well.
Yeah, sometimes it's a struggle to get people to understand it's not a zero-sum game. It's one boat, as you said. Yeah. It
is one boat, and it's like we're on one planet.
Yes.
It's the idea of unity and trying to get that message across. That my gain will be your gain.
Yes. Okay, there are no more questions or comments. Thank you, Dr. Jones, for giving us your vision. And we're going to commit ourselves to working towards this vision, because we all need to survive. True.
The message is, as you said, is not a no-sum game in terms of helping someone else, but that person may come around and help you. And one last thing I would like to say is that you have to realize that, I'm so happy that universities are starting to get rid of the GREs as a basis. because my GRE wouldn't have never gotten me into Berkeley. And it's, in terms of training individuals, I've always looked for that person with passion. Because of my mentor said, in the end, that person with passion will be at the same place or further than the person that you might bring on that already know where they want to go.
Okay. Well, thank you, Dr. Jones. There is one more comment from Shan Trotter. She's saying she's a proud recipient of your intelligence and professional guidance, and is talking about nonprofit, public, for-profit sector blurring lines more and more, and that the resources that were once an opportunity to advance these issues are getting smaller and more selective. What is your suggestion for reinventing your lessons for a corporate type environment?
I think sitting down and talking, the idea is we've become so siloed, and we continue to become more siloed, that we all think we have the answer, and we don't. It's crossing across both nonprofit and profit. I started right before COVID took place, an effort called Resources for Living, which brought in both profit and nonprofit groups to address health in underserved communities. And it was interesting that we had about 45 entities at our first meeting. The number of people who had not talked to each other who were in the same field. One just happened to be for profit, the other happened to be for nonprofit. But they needed each other's resources to be more effective. And it didn't take anything away from it. And the other was we had 6 federally qualified health centers sitting in the same room. None of them had talked to each other because they were so afraid that if they did, the other would gain an advantage in terms of getting the federal funds. And therefore, they kind of hoarded. But after the first Resources for Living fair we had, they realized that they each could benefit each other in terms of gaining those funds, and that they not only benefited themselves, they benefited the communities even better in terms of that they serve, because the other federally qualified health center had a resource that their community needed that they didn't have.
Yeah, that's definitely important.
Yeah.
Okay, well, let me close this out. Thank everyone for joining us. And I hope to see some of you all at the ASCB meeting, the virtual meeting that starts in a few weeks, in the beginning of December. And thank you, Dr. Jones, again.
Thank you.